speaker is Dr. Malay Dhebar, eminent senior radiologist, multi-speciality in diagnostic. He is working in Path Imaging Center, Rajkot, and he is former associate professor radiology at GCRI, Ahmedabad. I would like to request Dr. Malay Dhebar sir to start his talk, please. And I would like to request all other speakers, please keep yourself muted. It creates lots of disturbance. Yes, sir, you can start.
Yes, sir. Good morning, everybody. I think I am audible and the slides are okay.
Yes, sir, you are audible. We cannot see the slides.
So, the slide. At the onset, I must thank the Ophthalmic Society of Rajkot, Dr. Porwal and Dr. Bapal, for letting me share the experience on the HRCT in the present scenario. As we all know that auscultating a patient and being in close contact with a patient suspected with COVID-19 infection in itself is a risk to the medical professional. And the information that we get from just the auscultation is always limited. In this scenario, I think a rapid investigation and investigation which can throw light quite in advance of such a dreaded situation in the form of a HRCT of thorax is quite helpful. The good thing is that there are no government restrictions, and the bad thing is that it is not specific. But it is certainly highly indicative, and even in conditions where the RT-PCR blood test is negative, an early CT scan also can be quite indicative of the infection. I would like to clarify that I have collected data from and certain images from various studies done in Europe and China. But from the limited experience that we have, because in Rajkot, in private sector, there is not much rampant condition and we don't get so many patients as of now. But still, whatever experience we have is very much concurrent with the analysis of patients that has been done elsewhere. So studies demonstrate that CT chest can play a crucial role even when the blood test is negative. In early stages, patients with negative RT-PCR can display typical CT images which may indicate that patient is harboring the infection. In addition to the RT-PCR test, which can take a longer time, and the clinician and the public at large may not expect such a long time before they come to know that he or she is positive, and by the time the patient may have come in contact with lot of number of other normal people who are at risk. So in addition, patients with a positive CT and a negative RT-PCR should be included in isolation treatment, which may be helpful in controlling the source of infection as soon as possible. And it is likely that subsequently a positive blood test will nail the diagnosis. Now, what is the black and white that we see in the normal lung CT? Basically, a normal lung scan takes just 3 to 5 seconds of a single breath hold, and we get such pretty images where we can see that the black is air, and we can easily identify that these are the blood vessels. They are traversing up to the peripheral part of the lung. Now most of the lung here is normal, and we can divide the lung by thin fissures into the upper lobe and the lower lobe, and this is the peripheral part, the central part of the lung. And This is how is the sagittal image, where this is the upper and the lower lobe. So any patch that we see in a background of black lung is the pathology. In the subsequent slices, we will also see how easy it is to see and identify the pathology in a lung. The hallmark of the diagnosis is the GGO, the ground glass opacity, which is a faint patchy opacity seen in the lung, where we can see the underlying vessels traversing through the patchy lesion, and this is the first finding seen in the early stages of the infection. So we will see a couple of cases, and that will show us how we can confirm or come near to the diagnosis. Uh, this is a patient, 50-year-old female, early symptoms, and the CT that we see is here is that there are faint patchy opacities in the basal part of the lower lobe. After about 4 days, there is some progression in the density and size of the lesions, and subsequently the lesions resolve. In short, this is the normal pattern in which the disease appears and disappears. This is in spite of the fact that the confirmed report we got was after 6 days of the symptoms. Sometimes repeated tests may be necessary to clear the doubt whether actually the patient has a COVID infection or not. Second case that we see is that again a 62-year-old patient with a negative blood test, but the symptoms were typical. And here what we see is, this is the typical ground glass opacity. It is patchy cotton wool-like opacity, and we can see the blood vessels traversing through the opacity, which is typical of a ground glass haziness. And the lower lobe peripheral part of the lung is the classical site of the starting of the infection. And subsequently, as we can see, that the density of the lesion may decrease, the size may regress, but it will become a little more fibrotic. And here see, this is a patch of consolidation. We cannot see the blood vessels traversing through it. Here we can see the blood vessels traversing through the opacity. So this is a ground glass opacity, and this is the dense opacity. So the characteristic findings that we can see is that the GGO, or the ground glass opacities, may be single or multiple, mainly in the lower lobe, in the peripheral part of the lung. And in the early stages, it is just ground glass opacity, and on later stages, it may be, apart from the ground glass opacity, some dense ill-defined consolidation, which in later stage, at the time of resolution, shrinks normal and decreases in size subsequently. But the important negative findings is that there is never a pleural effusion, pericardial effusion, lymphadenopathy, or consolidation at the initial scan. Subsequently, when the patient develops complications, all these things may be present, but the first scan will just show GGO or maybe some patch. Classical case, here what we can see is the 5-day, 8-day, 10-day, and 15-day. Faint patchy ground glass peripheral opacity becomes denser subsequently, and then it resolves and becomes smaller in size. So an early scan is a very important prognostic marker. Whether the blood test is positive or not, a first scan can decide how the patient is going to behave on subsequent days. For example, this is patient 1, this is patient 2. Here the lesions are small and they mildly increase in size, but they are just peripheral. In this patient, at the time of presentation, there is a lot of patchy ground glass haziness, both the lobes. This is the upper lobe, this is the lower lobes. Both the sides of the lungs are involved, and they are quite progressive. And here we can predict that this patient certainly is not going to behave or give cooperate or will need aggressive medical management subsequently. Another patient that we can see, this is scan number 1 after 4 days, and just the first follow-up scan, there is rapid increase in progression in the patchy lesions, and this needs to be controlled with aggressive medical management. In short, this has a great prognostic value. The first scan and the subsequent scans are very, very important. So the peak range varies as per the severity. In mild disease, the peak may be as early as 3 to 5 days. In moderate disease, it can be as in 13 to 15 days, and in severe disease, it can extend quite a bit beyond 15 days. And many a times we come to know that it takes about 1.5 to 2 months before the patient comes back to the normal stage. No doubt the evaluation of the ground glass opacities is subjective, but there has been a scoring system that is involved, and we can come to a conclusion from the score of the parenchymal involvement of the lungs. For example, if on presentation the score is 10 and subsequently it progresses to 18, means that there is a significant increase in the disease condition involving the lung parenchyma. This is the dreaded situation. The first scan, very small patchy areas at the base, and subsequently florid lesions occupying entirely both the lobes. This is all non-aerated lung consolidation with signs of acute respiratory distress. This may be the terminal scan. So consolidation, large in size, typical picture of ARDS is the fatal finding that we can see on subsequent follow-up scans. Acute pulmonary embolism, as we know that the D-dimer, our previous speaker said, that they are prone to have pulmonary embolism, and it is irrespective of the condition of the patient. Even in a mild degree of COVID infection, patient can harbor a pulmonary embolism. So the plain X-rays always take a back seat, of course, because the findings are very minimal, and maybe later on they may show the findings, but here the catch is that the earlier we come to know, the better we can treat the patient. However, in crucial patients, CT may not be possible, and portable X-rays is a very good handy tool which can help the clinician to monitor the treatment that is being given. So the sensitivity of an X-ray varies from 60 to 80%. On later stages, the sensitivity is much higher. Just to show a couple of X-rays, the first X-ray hardly you can see. Even radiologists may take their own X-rays with a pinch of salt and not confirm whether there are subtle lesions at the periphery. But then subsequently, the lesions encroach upon rest of the lung and then involve the entire lung. Here also we can see that the lesions progress from periphery to the center and is involving the lower lobe. Radiation exposure is a necessary evil. We cannot prevent the information that we can get from a CT scanner by just doing an X-ray and believing that all is well. A scanner, faster scanner, a multi-slice scanner, the scanning time is much less and the radiation is also not very high. This is an interesting case that we did. There were florid, dense, patchy, multiple opacities involving both the lung fields, and we thought that this may be some acute pneumonia followed by some secondary infection. But the clinician always keeps the trump card. After about a week, we did a scan, and this is the magic that we saw. Most of the lesions had disappeared. Residual patches that we saw, and this was a Legionella pneumonia. In short, as all of us know that CT is not specific. However, it can be sensitive. And the list of ground glass opacities that we see on a chest scan, the list is endless. It can vary from viral pneumonia to bronchoalveolar carcinoma to post-radiation changes. In short, a proper clinical history, epidemiological study, and blood investigations will certainly be necessary in concurrence with a CT finding. So the pitfalls, what we can enumerate in case of a CT is, as we saw, that the specificity is low. Very rarely a CT can be normal in very early stages. It may be difficult to perform a CT in a critical ill patient because patient cannot cooperate for a breath hold study. The CT images are non-specific. It can be very similar in H1N1 SARS or in other similar conditions as we saw before. And there is certainly a small risk of radiation to the patient. Hospitals and scanners scan where the areas may need to be sanitized properly and all contacts must be cleaned after the scanning of a particular patient is being done. All of us know that the disinfection of the rooms is very vital. Alcohol, soap, and chlorinated disinfectants are freely used, which helps to protect ourselves as well as our department. Now, to conclude, why a CT scan is a must. In short, patients with a positive CT and a negative RT-PCR should be included in isolation treatment to prevent further spread in case if the patient is harboring the COVID infection. CT is helpful in monitoring the disease progression and evaluating the effectiveness of the treatment. CT provides fast method to recognize the disease early, and it contributes to confine the epidemic.
Thank you.
The patches have resolved. Previously, there were florid infection in this patient, and this is how maybe the end result after about 20 days. So we all pray for all patients, whatever part of the world they belong to combat and conquer the deadly virus from the north of our country. Jai Hind. Thanks, everybody.
Thank you, sir. Just a couple of quick questions. How
Yeah.
specific is the HRCT with respect to coronavirus and COVID?
In fact, as we have come to know that even it is positive in case of an asymptomatic patients, but specificity is always not a very, as we came to know that atypical infections, certain non-infective conditions also may show that even allergic pneumonitis may show patchy ground glass haziness.
Are
So
there
based,
are there any classical signs which go in favor of COVID and
see,
which rule out other things,
see the
relatively
class,
speaking?
yeah, the classical signs that we saw is that the basal peripheral patchy ground glass opacities at the first scan is highly suggestive of a COVID infection, whereas scattered ground glass opacities can occur in H1N1 or other viral pneumonitis as well, but the distribution of the basal dependent lower lobe patchy areas are one of the classical findings, and we all know that patients with COVID infection are many a times treated in a prone position, and that is
Right.
why that is to give proper aeration to the dependent portion of the lung and for proper drainage of the secretions, which will prevent further complications in a compromised lung.
Right, sir. Why I'm asking you is there's a lot of
Yeah.
interest and talk about using the HRCT because the lab tests are a little bit cumbersome. They have a lot of protocol attached to them, and sometimes they are false negative. So, in terms
Yeah.
of reliability, where will you place the HRCT vis-a-vis the lab tests?
See, if the HRCT is normal, we go the other way around. It is more than possible that the patient will not have an infection, but very rarely, maybe in early stages, it may turn out to be normal, but the sensitivity of CT is much higher and probably is a greater reliable tool to screen out a patient for an early infection.
Right, sir. That was a nice presentation. Thank you very much, Dr. Malay Dhebar. Now,
Yeah,
from this point, we move on to the